There are a number of new things in the guidelines for general practitioners. Importantly, the classification of heart failure with preserved ejection fraction is still more than 50%, but less than 50% is reduced ejection fraction. There's new guidance on the use of ARNIs in patients with low ejection fraction. In patients with type 2 diabetes, the use of SGLT2 inhibitors to reduce the chance of developing heart failure and prevention. There's more guidance on devices as far as patients with non-ischemic cardiomyopathy with a lower recommendation. There's also guidance on nutraceuticals, or the lack of benefit of nutraceuticals except perhaps with omega-3 fatty acids. Also, there's guidance on comorbidities as far as sleep apnea, where we do not recommend auto-set support in patients with central sleep apnea and in patients with obstructive sleep apnea just for symptoms using CPAP. There's also guidance as far as treating patients with telemedicine and non-pharmacological therapy with nurse-led up-titration protocols and programs to keep the patients out of hospital. It's important to remember that the diagnosis of heart failure is a clinical diagnosis where someone has shortness of breath, ankle swelling, fatigue, where the heart is not able to meet the metabolic demands of the body. That hasn't changed. What has changed is how we're classifying their heart failure. We said that if your ejection fraction is less than 50%, it's not normal. So in those circumstances, we said if your ejection fraction is less than 40%, we called it a reduced ejection fraction. And if it's more than 50%, we said it was preserved. Other classifications have said 41% to 49% being mid-range ejection fraction. That's very confusing. The data really says that if your ejection fraction is impaired, that you use treatment. If it's preserved, you think about other ways of managing. So if your ejection fraction is less than 50%, it's reduced ejection fraction. But if it's between 41 and 49%, we made a much lesser recommendation for the treatments because the evidence is not as strong. Heart failure preserved ejection fraction is a difficult thing to try and confirm. These patients look like heart failure, smell like heart failure, but when you do the echocardiogram, they have preserved ejection fraction. So in those patients, the data is nowhere near as good. In fact, most of the trials that have been done have shown no benefit as far as symptoms, survival or hospitalisation for patients with heart failure with preserved ejection fraction. So it's important we differentiate those patients because the ones with reduced ejection fraction we do have evidence with ACE inhibitors, with beta blockers, with spironolactone, and if the ejection fraction is less than 40%, with ARNIs in improving survival, improving symptoms and reducing hospitalisations. But with heart failure with preserved ejection fraction, we have no data. So if they have preserved ejection fraction, you have to think about treatments to treat the comorbidities and trying to treat the patient symptomatically because at the moment, nothing else has been shown to benefit. The most important test in patients with suspected heart failure is an echocardiogram. It tells us about cardiac function, so we can differentiate preserved ejection fraction from reduced ejection fraction. It excludes valvular heart disease, wall motion abnormalities in case the patient's had a previous myocardial infarct, pericardial disease, pulmonary hypertension. So an echo is the key investigation. Once they've done that, we think about ECGs, looking at cardiac rhythm, myocardial infarction, chest x-rays, pulmonary congestion. And if the diagnosis is still in doubt, a BNP or N-terminal proBNP can be quite helpful in differentiating if someone does not have heart failure. If it's high, the diagnosis may still be in doubt. But I always say, when in doubt, think about your cardiologist. Refer the patients to a cardiologist if the diagnosis is in doubt or if you're not sure about management. I think most patients with heart failure should be seen by a cardiologist at least once. The most important thing when you see a patient with heart failure is, are they congested or are they not congested? If they're congested, you should be going with an ACE inhibitor, and if they're intolerant of an ACE inhibitor, an ARB. Then after that, once they're euvolemic, thinking about a beta blocker. If they're still congested, you can give spironolactone before you give the beta blocker, and under those circumstances, you try and get the patient euvolemic. We try and avoid diuretics only if they're congested. We give the diuretics, otherwise diuretics do not improve survival. They're the important things to remember. Beta blockers should only be given to patients once they're euvolemic, otherwise the patients may deteriorate temporarily. So we gave a strong recommendation for ACE inhibitors, or ARBs if they're intolerant to ACE inhibitors, beta blockers and spironolactone if the ejection fraction is less than 40%, and a weak recommendation, but still a recommendation, if your ejection fraction is 41 to 49% with reduced ejection fraction. We also gave a strong recommendation if someone has heart failure with reduced ejection fraction and it's less than 40%, and they're on an ACE inhibitor or an ARB for 3 months, to change the ACE inhibitor or the ARB to an ARNI, because that leads to further reductions in hospitalisation, improvements in survival, and improvements in symptoms compared to the ACE inhibitor or the ARB. We also talked about using nurse-led titration clinics to up-titrate the doses of ACE inhibitors, ARBs, beta blockers, and ARNIs. And also, we talked about using nurses in their role in the community to make sure patients take their medications, because compliance is so important. If the patients don't take the medication, they're not going to get better. The ARNI class of medications in patients with heart failure with reduced ejection fraction has been a real blockbuster. It's been a revolution in our management. Before, all the other trials had used drugs on top of other treatments. This actually compared an ARNI to an ACE inhibitor, our first-line treatment, and showed significant improvements. A 16% reduction in overall mortality, a 21% reduction in heart failure hospitalisation, and a 20% reduction in cardiovascular mortality or heart failure hospitalisation. These drugs improve symptoms and survival. So that's instead of an ACE inhibitor. But you must remember that the only thing they do more than ACE inhibitors as far as side effects is concerned is that they lower the blood pressure more. So start low, go slow. And if you're changing the patient from an ACE inhibitor, you need a 36-hour washout period off the ACE inhibitor before you start the ARNI. If they're on an ARB, you can convert them straight away. Watch the potassium, because the potassium can go up. Watch the creatinine, because the renal function can deteriorate. Start low and go slow. If you start low and go slow and up-titrate slowly, there's less risk of hypotension. Monitor the patients carefully, because if you do, they will get significant improvements in symptoms and survival. Patients with type 2 diabetes are recommended to take SGLT2 inhibitors to prevent the development of heart failure hospitalisation, because that's been shown to reduce heart failure hospitalisation by 35%. This is not a treatment for patients with heart failure and diabetes, but if they have diabetes and they take these medications, there can be a 35% reduction in heart failure hospitalisation. The subgroup analysis of the EMPA-REG outcome trial did show similar benefits in the small percentage of patients who had heart failure, so it looks like these medications in patients with and without heart failure can prevent heart failure hospitalisation and reduce cardiovascular mortality. The other thing we said in the guidelines is that thiazolidine-diones are no longer recommended in patients with heart failure because they increase fluid retention and increase hospitalisations. As far as nutraceuticals in the management of heart failure is concerned, we did a really big analysis. We looked at many studies, and the data was either poor, small, or non-existent. In fact, with all the nutraceuticals we looked at, the only one with even small amounts of evidence was the omega-3 fatty acids. In the GC heart failure trial, there was a small but significant 9% reduction in overall mortality with omega-3 ethyl esters in patients with chronic stable heart failure. So that was the only one that had any real data. All of the other nutraceuticals we looked at showed no data, small studies, non-well randomized, really with poor studies. So I would have to say that if a patient said to me, should I take this nutraceutical? I'd say there's no evidence. If you want to take it, you can, but we do not recommend any of them any longer, except for perhaps the omega-3 ethyl esters. Disappointing, but true. Non-pharmacological management is really important in patients with heart failure. There was a strong recommendation for moderate intensity exercise where patients can walk and talk at the same time. There was also recommendations for nurse-led heart failure programs where the patients visit the patients at home, where the nurses visit the patients in hospital as well, and follow them up via telephone. For patients who can't get to see the doctors, telemedicine for remote patients is very helpful to make sure they take their medications and they're on the right track. And also we made recommendations for managing comorbidities such as type 2 diabetes, chronic kidney disease, chronic obstructive pulmonary disease in managing these patients. And importantly, there are some new recommendations for patients with sleep apnea. In patients with central sleep apnea, we actually made a strong recommendation against using CPAP because that has actually been shown to increase mortality. And in patients with obstructive sleep apnea, CPAP mask has only really been shown to improve symptoms as far as reducing sleepiness and tiredness is concerned. Otherwise, it really didn't help their heart failure status. So it's important to manage the patient as a whole, managing their comorbidities, because that can have a positive impact on their heart failure status. The key things to remember from the new heart failure guidelines are that if someone has an ejection fraction less than 50%, it's not normal, and we should be using mandated treatment such as ACE inhibitors or ARBs intolerant, beta blockers, spironolactone. The new recommendation that if a patient is stable for 3 months on an ACE inhibitor with a low ejection fraction below 40%, to change their ACE inhibitor or their ARB to an ARNI. If they've got diabetes, think about an SGLT2 inhibitor to reduce the progression in the patients with heart failure. If a patient has sleep apnea, to avoid using auto-set CPAP because in central sleep apnea it can increase mortality, and in obstructive sleep apnea it just makes them less sleepy. And thinking about non-pharmacological management with exercise, nurse-led programs, and for remote patients using telemedicine to keep them well and out of hospital, because that's our goal, to make people live longer, keep them out of hospital, and make them feel better.